So just like we did last evening, we're going to see some images in the abdomen, and these images primarily have been acquired at MGH, and there are some that I have borrowed from the literature. And basically, these images have been made possible by the grant that we received from RSNA. And the objective being that we want to see what the effect is on changing the scan parameter on the abdominal CT images, and how does it affect really the lesions in the normal structures. Well, since we did chest yesterday and we looked at the lungs, dropping the dose from 20 milligray down to 1.3 milligray, it really didn't affect the visibility of these small lung nodules or these other findings in the lungs. Really no sacrifice, and the reason was high contrast between air and the lesions. Right? Now, why I am rehashing this whole thing now is that the same lesson that we learned from lungs yesterday goes for high contrast to CT colonography, right? And that's how CT colonography becomes a lower dose exam. For example, this flat polyp here, about 8 millimeter, right, can be very easily seen at about 30 to 40 MAS between a CTDI volume of 2 to 4 milligrays. That's all that you need to do a good CT colonography. Right? So that would be your target CTDI volume for each of your series. If you're going to do supine and prone, so then each can be done between 2 to 4 milligrays. Now, remember, this is just filtered back projection. If you are going to add iterative reconstruction, you would drop the dose by about 30 to 50% depending on where your radiologist is comfortable with. So what else is high contrast in abdomen like lungs? Well, not that many CT colonography-like lesions, but yes, there are kidney stones, as was alluded previously, and these kidney stones also have high contrast between the calcium, because many of these are calcified, and the soft tissue where these calcified stones sit, right? And therefore, these also allow you to use lower dose. May not be the lowest dose, which I basically give to CT colonography, but certainly lower dose as compared to what you would use for your routine abdomen. Here is an example from our post-mortem imaging where we scanned this cadaver, which was 65 kg, not very big, BMI of 26, but you can see that there is about 1 to 2 millimeter stone here in the left kidney. And this was scanned at 30 milligray, and then we dropped the MA, kept the KV constant at 120, right? And then we came all the way to 3.4, and I can still see that 1 to 2 millimeter stone without any problem. Right? So certainly much lower dose than you would expect from a routine abdomen. Typically, as was alluded to in the previous lecture, when the patient comes from first CT of the kidney stone, the dose should be 30 to 50% lower than what you would use for your routine abdomen. Right? That's the starting point. And then if the patient is going to come for follow-up studies, the dose drops additional 25% as compared to what he would have got for the previous ones. Now, kidney stone, again, depending on how big or how small the patient is, generally 2 to 6 milligray is sufficient. Right? You do not need to be in double digits for your kidney stones, right? Regardless of how big the patient is. Right? And if you add iterative reconstruction, then it further improves the sensitivity. So we start with a slice thickness of 5 millimeter for kidney stones, and some people might say, well, is it too thick for detecting small stones? Well, certain places would go to 2.5 or 3 millimeter. If you are one of those centers that do go for thinner slices, you will find that this CTDI is going to be lower than what you need. In that case, I would invest some time and do some other creative things like creating a maximum intensity projection images or MIP images, which help you cut down the noise, help you enhance the calcified stones from the noisy surroundings. And that's how you can get some of the dose reduction, even though your radiologist may be using thinner slices. You have to use automatic exposure control technique. Most studies, point out that 120 kV is ideal. And the reason is that 100 kV can give you problems in the pelvis, where the different artifacts and the increased noise can be troublesome. If you want to go lower kV for that, I would suggest that you use a much lower threshold, than what you use in the chest, for example, 60 kilogram, right? So again, we don't really use, fortunately, thankfully, CT for detecting gallstones, but this was just a post-mortem CT. So we just wanted to see if we can see that 3 millimeter gallstone at all the dose levels. And not surprisingly, you can see it from all the way from 30 milligray down to 3 milligray or so very clearly. Not a problem. However, on the same images, you can see that there is some free fluid or ascites in the abdomen, right? You can see the liver here and you can see the fluid here. This is 30 milligray. I'm diving it down to 24. I can still see it. I'm at 13 milligray. I can still see it. And now I'm pushing it at 7 and it's beginning to fade away. You do not want that to fade away when you are doing a routine CT of the abdomen. So that means that the calcium can tolerate much lower dose. However, when it comes to soft tissue or a routine abdomen, perhaps you need higher dose, especially in this size patient, at least, than 7 milligray is offering. Okay, bone lesions, we saw in the chest yesterday that bone lesions generally not a problem. Again, a high contrast situation, whether it's dense lesion or whether it's a lucent lesion. This case happens to have a lucent lesion here. And basically it was a metastasis, and we were able to see it all the way from 12 down to a CTDI of 3, no problem. So if you're looking for these metastases in patients with prostate cancer or others, if that's the focus, then a lower dose is just as well. So, is there anything else now remaining as far as high contrast goes, right? Well, there are, when you give iodine and when you are only looking to get CT angiography. For example, CT angiography is done for abdominal aorta. It's done for kidney donors. Basically, it's done for, you give contrast and, for liver donor evaluation. And then you also do it, you also do a high contrast situation where you inject contrast, a lot of it, and then you're looking for hypervascular lesions, as Dr. Nelson had pointed out earlier in his excellent talk. In those cases, instead of playing with the MA, we tend to play with lower kV. Remember, the lower kV brings you closer to the cage of the iodine. The iodine appears much denser at lower kV, and it improves the contrast. You can tolerate more noise, and therefore you can tolerate lower dose in these cases. So the next set of protocols will be for places where we are going to give contrast, because reducing kV when you have contrast on board basically improves the CT numbers of the iodine. So using lower kV, you will get more HU for iodine. So example, this is basically from a study that was published by Shindra in Investigative Radiology, where they looked at different protocols for CT angiography of the aorta. This is not an uncommon indication, right? So what they said was, well, because you're going to inject contrast, which is typically 4 to 5 cc's per second, right? They used 3 different type of protocols, and they assessed, well, what can be achieved with lower kV? There were 2 things that they were clearly able to achieve. One is, clearly at 100 kV, their dose is about 7 milligray, which is roughly about 40 or 50% lower than what you would have expected at 120 kV or with a routine abdominal CT in an average size patient. They also investigated 80 kV. Now, this was obviously done in non-obese patients, typically less than 80 kilogram or less than a BMI of 30, right? In addition to basically getting diagnostic CTs at much lower levels of radiation dose, they also found that they can actually reduce the total amount of contrast to 45 cc's. Typically at 120 kV, you require about 100 to 120 cc's of contrast to get a good quality study. But they were able to bring it down by about half. Right? So you can administer less of the contrast and still get the same level of enhancement and quality. Again, multiphase CT of the liver, Dr. Nelson actually pointed out very clearly what the advantage is. This was done at 140 kV. Basically hard to see those enhancing lesions. But when the kV was dropped to 80 kV, you can actually begin to see the lesions much more clearly. And when you apply iterative reconstruction technique here, you basically help reduce the noise. Not that it's making any other lesions, any lesions more conspicuous than what it was, than what's seen here, but just that the noise becomes less. Right? This is again a paper from his group that was published in Radiology. And again, the doses are fairly low compared to 140 kV, which is not something that I would have recommended as a starting point. Unless the patient is 300 pounds or greater, morbidly obese or severely obese, for all CT angiography of the studies, I would have stuck to 120 kV. Right? Unless you're scanning maybe a reasonably, maybe like a borderline obese patient and your scanner did not allow you to go beyond 400 MAS or so, which can happen in the older scanners. So this might have been one of those. Another example, this is a Japanese study published in Radiology. And again, these guys actually did 120 kV. So a good starting point, looking for that tiny focus of enhancement there. And then they dropped the kV to 80 kV. And they, of course, used dose modulation. With the filtered back, this is the column that shows the result with filtered back. And then they used the same 80 kV, they applied some kind of an hybrid iterative reconstruction technique, right? And you can see that this image is less noisy as compared to this. The lesion is quite well seen here as is seen on this one, right? So just dropping the kV, you can actually tolerate much more noise because the iodine stands out much brighter. So you do not really need to essentially have iterative reconstruction. It obviously does help, but it's not crucial. Right? And if you are planning to add the iterative reconstruction technique to low kV, this paper actually tells me that they overshot the radiation dose. They didn't really get the full worth of their money by applying the same dose with filtered back as compared to iterative reconstruction technique, and they could have gone even lower. And that's when the role of iterative reconstruction becomes even more important. Again, another thing that we do, as was alluded to in the previous talk, is cut the scan length when you're doing multi-phase exam. For example, if you have to do arterial, portal venous phase, delayed phase, what we do is that if we have to do liver exam, the arterial just goes through the liver. Not more, not less, just through the liver. Right? The portal venous phase is the most important phase because it shows the rest of the abdomen. If you are interested, you go through the entire abdomen and pelvis based on the indication. And if equilibrium phase or delayed images are needed, you only go through the lesions. We do not go beyond that, right? So and then again, we do not do any non-contrast imaging for our liver. We have eliminated non-contrast imaging, so it's never a 4-phase study. It's 3-phase, but the dose is actually only 2x. It's not 3x. Another thing to remember is that because you have higher contrast density or actively circulating contrast in the arterial phase, that's the phase where you want to target lower kV. Right, because you're just interested in picking up iodine-enhancing lesions. So lower contrast, lower kV actually helps you improve the detection, cut the dose down even more, and then you can also see more lesions here. And again, you have to use automatic exposure control technique in almost all of your abdominal CT examinations. Okay, CT enterography is another place where there is higher contrast. And this is kind of a negative contrast because in this exam, many places would administer a low density contrast. They will distend the colon or they will distend the intestine with that. And it's typically done for inflammatory bowel disease such as Crohn's or ulcerative colitis. In this case, you can see that there is thickening of this small intestine loop here. And again, you can see the same. What these people did was there's a error here. This should be 100 MAS. So here's the filtered back 200 MAS 7 milligray. Here's filtered back 100 MAS 3.5 milligray. This image is fine. This is how typically our CTs at MGH look like. It's nothing wrong with it. We can read through it. They apply iterative reconstruction. Yes, it does denoise the image. No, it does not add any additional information whatsoever. What does it tell me? Well, this paper perhaps kind of over-radiated this patient for what they were using. They could have gone even lower, and then the advantage of iterative reconstruction would have kicked in. But regardless, this is another low contrast situation where I would perhaps use lower MAS rather than lower KV. And the reason is that this is not a place where I have given iodinated or positive contrast. So lower KV will disproportionately increase the noise and may not help. And plus, most of the pathology is in the pelvis, where you have dense bones. You do not want to use too much lower KV when you are there unless you have a good iterative reconstruction technique. So, how about the routine abdominal CT? Well, it certainly does need higher dose than CT coronography in kidney stones. It also needs higher dose as compared to your routine chest, because you're looking for low contrast things that can be small, that can have very little difference from the background, and therefore you need higher dose. Some of the lessons that I use, well, always have to apply automatic exposure control technique. If you have small patient, if you have given contrast to the patient, you can use lower KV. Many places are actually beginning to switch to 100 kV as their default start KV for average or smaller size patient, especially when they have IR techniques available, right? And we are going to see a change in the landscape over the next 2 or 3 years. Whether some people like IR or not, I think the default for abdominal CT is going to be 80 to 100 kV in the very near future. Because not only it drops the dose, but what's the most crucial part that makes you do a CT? Well, to pick up a lesion. Well, then if you have given a contrast to the patient, what's the best KV that you can use? The lower KV. So it not only makes sense from the dose point of view, but also from the point of view of being able to detect and see more things and being able to characterize more things, whether they are something to be worried about or not. Another thing is arms. Well, whenever possible, keep the arms out of the field of view. It especially bothers me because we do a lot of post-mortem imaging. None of the dead bodies move their arms out. Not surprising, right? Not surprising. So we have to tie them out to take them out, right? So, it just emphasizes that sometimes these dead bodies have been dead for a while, and then they are quite stiff, and you do require a lot of arms to move these arms, right? So, but just that, it's extremely important. I cannot overemphasize this to keep them out. You either keep a pillow between the belly and these arms, or try to put them up beyond, because that is just something that I cannot fix. Right? The artifacts are really bad and the dose does go up. A patient motion artifact should be avoided, right? A pitch of 1 or greater is ideal for all abdominal CT exams, right? You do not want to be too slow because motion artifact is a problem. Certainly in some patients who have more peristaltic activities, you do not want to be too slow there. And then, of course, a rotation time of 0.8 or under is ideal, right? 0.8 second I would keep reserved for someone who's like big patient, like someone who's more than 200 pounds or something. But under that, we typically, our default rotation time is 0.5 second for most abdominal CTs, except when the patients go above 250 or so. That's when we start increasing the rotation time. Again, one has to use automatic exposure control technique, because in smaller patients it will drop the dose, in larger patients it can increase the dose. And that's how you size the protocol to the patient size. You can see that in all of my talks, I always start from clinical indication. The number one golden rule is justification of the exam. The number two thing that we do for protocol optimization is not the size of the patient, but why is the scan being done? And then the third thing that the vendors actually do a brilliant job at is sizing the dose for the patient size. Right? And that's why I have it less in the priority. Liver lesions, right? Again, post-mortem CT, that's why I've scanned at 5 different dose levels, starting from 25 milligray all the way to 1.7 milligray. And, you will say, did you administer contrast? Did I administer contrast in this patient? Well, no, this patient had contrast CT just before he died. When we brought the body down, it was still warm. And you can still see contrast there. Right? And you can see the lesion very clearly, very nicely marginated lesion. And here, at 1.7, very difficult. I wouldn't accept this. Here, fuzzy. I would not accept this, right? So these doses are out for sure. Here, I can see it. It's still too noisy, although I can see this big thing. But, my vessels here don't look very nice. right? But at 14, it looks good, right? So somewhere between 7 and 14 is the sweet spot for this patient for routine abdominal CT, right? And also you can see that the thing is that most of the times you will be able to see lesions, but then you will not be able to say anything about what exactly is that lesion likely to be. Another example here, there is another lesion in the liver and the same effect. The lesion margins getting blurred, you can still see it. And another thing that you notice is that, well, the vessels are somewhat fuzzy, they're not as great, and here you're having trouble seeing it. All the images are filtered back, all of them were acquired at 120 kV, and they're all real images. And this is the lesion basically. One other thing that we do in our post-mortem imaging is that we don't just leave the bodies after we are done scanning. We take them down to the morgue and the body undergoes a full body autopsy. Then we go there with our cameras and we snap photos of the section because we're trying to match, well, what does this lesion correspond to? See how sharp that margin is? Helps you make the decision whether this is likely to be a benign, such as a cyst, or something more aggressive. Clearly looks much more sharper here than it looks on some of the lower dose images. So this is kind of the information that you will miss if you are too low. Another example where this patient has diffuse fatty infiltration of the liver, right? And again, you can see that these doses are too low. May have been okay for kidney stone. This is also too low. But 10 milligram is perhaps a nice dose for this patient, right? All the images are 5 millimeter at 120 kV. A CT hematuria. Basically, Dr. Nelson elegantly pointed out that we should try to combine phases by using different phases of contrast injection rather than doing a number of different phases with CT. So we can use a split bolus technique, and instead of doing 3 or 4 phases after contrast, we just do one phase where we basically see the nephrogram as well as the excretory phase very nicely. Should use the automatic exposure control technique in these cases. And again, when you're going to do a CT urography, again you have iodine on board. It's a higher contrast exam, right? So you can and should use lower dose than what you would have used for your routine abdominal CT. Right? You would use a lower dose because remember, our yield of hematuria protocol, most of these patients anyway end up getting a negative exam. Because the most common cause is urinary tract infection, which cannot be seen. Of course, I'm not implying I want to miss a small tumor, but it still is an exam with low yield. And that's why when we have to use this protocol, our doses are about 25 to 30% lower for this post-contrast exam than they are for our routine abdominal CT. Right? So again, another thing that we do is that because we are doing non-contrast imaging, before we do the post-contrast, but since the non-contrast CT doesn't really add too much information in the liver, we don't start from the top of the liver, we start instead from the top of the kidneys, right? And then go down and to the pubic symphysis or lower if there is need. But for post-contrast, one can go higher from the top of the diaphragm and then can cover the entire abdomen pelvis. Remembering that one has to use automatic exposure control technique, A, and then B, the doses should be about 25-30% lower than what you would have used for your routine abdominal CT. CT for appendicitis. Now, there are a lot of people who have reported that, well, this needs to be a very low dose exam and all that, especially papers coming from Europe and from Asia, which have reported like rock bottom doses that are even lower than some of the kidney stone doses. Reason being that this exam gets done not so infrequently in very young patients. Right? Our protocol at Mass General is pretty straightforward. When the patient comes with a suspected appendicitis, they have, if it's a regular hour, we try to get a graded ultrasound. If that's not diagnostic, I'm talking about patients who are less than 18. We go for MR. When MR is non-diagnostic, we go for CT. It's never the other way around. Right? So it doesn't get that much. We don't get them as often as we used to. Right? But there are papers that have said that, well, you can drop the dose to about 30 or 40 MAS, use AEC. I take them with much skepticism because the ability to detect appendicitis depends not only on the patient's size but also how much fat he has around that appendix. right? So I would not go crazy and cut the dose like in this study and basically drop it by about 70%. I would not do that. I do not do that at MGH. Instead, what I do is that I go from L3 level, half of the abdomen, and then go and scan up to symphysis pubis, right? So I reduce the scan coverage because that's the region where appendix is likely to be present, right? This is how we cut the dose down, right? You can use automatic exposure. Well, in fact, you should use automatic exposure control to size the dose according to the patient size. But I would not go too aggressive here because you can miss this. And this is one thing that you do not want to miss, because if it's a negative CT, the patient does not go for surgery, which is a significant advantage or benefit of CT. You know, rather than just doing a needless appendectomy and removing the appendix and making the patient stay in the hospital for a number of days and other complications. So, in summary, well, for routine abdominal CT, for low contrast lesions in the liver, you do require higher dose as compared to other high contrast situations such as CT colonography, CT angiography, or kidney stones, or even detection of hypervascular lesions. Thank you.